So hello everyone, and thank you very much for coming to this workshop. I hope everyone had something to eat. All right, good. So I'm not going to show any slides. I thought instead we could have a conversation. And you know, if you'd like me, most of you heard my talk this morning. If you'd like me to repeat a few of the key recommendations, I'd be happy to do that. Or if you just want to ask questions and have a conversation about medication, I'd be happy to do that as well. And I think we're here to focus mostly on meds, but I'm happy to take an occasional question on another topic if people are interested in talking about something else as well. So, and thank you all for being here. I mean, it's just so amazing. This wouldn't have happened 20 years ago, even 10 years ago. And it just takes courage, to kind of face BDD and then decide you're going to do something about it. And so thank you all for being here. Really appreciate it. So what would be helpful? Do you want me to just kind of recap a few key points and then go into questions and answers, or would that be too repetitive? You want to hear just the few key things? So as I mentioned this morning, there are two recommended treatments for BDD. One is the cognitive behavioral therapy and one is medication. It doesn't mean other approaches don't work. It's just they haven't really been well studied, and so there's no basis for really recommending them. And so medications, can be really helpful for BDD. I think for people with more severe BDD, or especially if you have a lot of suicidal thinking or depression, I'd always recommend medicine, always. I think and plus cognitive behavioral therapy too, if you have more severe symptoms. I think if you have milder BDD, you've got a nice choice. You could do both, medication and therapy, the cognitive behavioral therapy, or you could just choose one or the other. And so I think it's wonderful that we have two different options, both medicine and cognitive behavioral therapy. The key with the medication is that the only class of medication that has really been adequately studied in BDD, and all the studies indicate that it works, are the serotonin reuptake inhibitors. They're sometimes called SRIs, they're sometimes called SSRIs, basically the same thing. And in the US, we have 7 of them available on the market, which is wonderful, because sometimes one will work when another doesn't. And just because you don't respond well to one doesn't mean you won't respond well to another. You really might. And so, should I repeat the names of them for you? I wonder if I can. I don't think that's a chalkboard. No. Well, clomipramine. Actually, can I write? I don't think so. Is it like a whiteboard?
I'll see if I can raise that. You keep talking and I'll see if I can sort it out.
So I think ones that I tend to prefer out of the 7, those medicines haven't been directly compared to each other in a study. So we can't really say is one better than another. I think in my experience, they all work well. Some are a little bit better tolerated typically than others, but as a class, they're all really tend to be well-tolerated medicines. So fluoxetine, fluvoxamine, sertraline, escitalopram, paroxetine, and these are all written on my website if you want to find me online at Rhode Island Hospital. You just Rhode Island Hospital/BDD, and in my book, The Broken Mirror. And I wrote a book in 2009, Understanding BDD, which is a more up-to-date version of The Broken Mirror. These medications are antidepressants. They're used to treat a whole variety of disorders. They're kind of like, I don't know if you've heard of like broad spectrum antibiotics that can treat a whole variety of conditions. Now they're not antibiotics, but it's the same idea. They're used for depression, they're used for panic disorder, they're used for various generalized anxiety disorder, OCD, obsessive-compulsive disorder, eating disorders, all kinds of things. They're really very helpful medications. And they're different though from other types of antidepressants because they also help cut back on obsessional thoughts and compulsive behaviors. So it's only the SRI antidepressants that are really highly recommended for BDD. So I'll find people come to see me on other kinds of antidepressants, and I don't recommend other kinds of antidepressants, but the SRIs, again, we've got 7 of them in the US. We've got, and you probably have them, that many here. One doesn't work, another might. Most people tolerate them really well. Now, you can't, you can get side effects. That's true of all medicines. It's true of aspirin, Tylenol, there's always that potential. But I think the key is we tend to start with a lower dose and then gradually push the dose up as you're able to tolerate it. And I think the main thing is to work with your doctor. And if you're having trouble tolerating it, you can let your doctor know and maybe lower the dose a little bit until the side effects go away. And then sometimes the next time you try to raise the dose, maybe just by less the next time, you do fine. And sometimes the longer people are on the medicine, the more easily they tolerate it. But most people have really no side effects and tolerate them very well. And they can just really, it's hard to imagine that a little pill, these are such widely prescribed medications. In the US, they're among the most widely prescribed of all medications. It's hard to believe that that can help so much, and yet they really, really can. They can completely get rid of BDD. We just did a study of 100 people with one of these medicines, escitalopram, and we found that something more than about a quarter, were completely free of BDD within 3 months. That was unbelievable. And the response rate, if you took it for the full 14 weeks, 80% were at least much or very much improved. I think the big reason people don't respond well to these meds is they don't get the dose up high enough, or they miss too many doses. They think, I'm only missing 2 days a week. But that's 2/7 of your dose. And you've got to take it every day, and you've got to be consistent with it and try not to miss any doses. And most people do quite well. Now, it's very hard to predict. When I prescribe one of these meds, I can't say for sure that you will respond, or you will, there's no way to predict that. That's true across the rest of medicine as well. If one blood pressure medicine is going to work for a specific person, but the odds are, if you take a high enough dose, and not everyone needs a high dose, it has to be individualized to you, the odds are that, it'll really help. And typically it helps you get better control over your own thoughts. It's amazing. People say, I just don't think about it as much. And when I do, it's easier to refocus on something else. It's easier to listen to the conversation I'm having and not be obsessing about how I look. I don't get such strong urges to pick my skin or rush to the mirror. I just don't feel it as strongly, and it's just easier to have fortitude and just walk by that bathroom without going in. Mood tends to improve, anxiety tends to get better. So, you can really have a lot of improvement. Often, suicidal thinking diminishes, typically. That's what we tend to see. So should I write down the names of the medicines again? Would that help? So, I think, is it Cipralex here? I should have learned all the brand names are different in different countries is the problem. The generic names are the same around the world. So, Oxetine, sertraline. Fluvoxamine. My handwriting may not be that good.
Katharine, are they ever prescribed together? Or do they have to be just one medication? Have there been any studies?
1, 2, 3, 4, 5, 6. I'm missing one. Oh, citalopram I don't use as much anymore because we've got a dosing limit. Even though it's never been shown to cause harm, really, we have a dosing limit, unfortunately, in the US, and I think you've got it here too, which is too bad. Well, I usually use one of these. But again, I think there might be a dose, there's a dosing limit in certain countries with this medicine because it can slightly change your EKG just a little bit, but there's never been any documented harm. So it's just a little on an EKG.
What's that?
Oh, I'm sorry, it's a cardiac, it monitors your heart rhythm and heart rate. So there can be a little bit of a change, but it's never been shown to be harmful to anyone, so it cause any arrhythmia or anything like that. So we can use higher doses in the US. So I think it's country dependent, but I like this one and this one. But they're all fine. They're all excellent. I think the better tolerated, this might be a little better tolerated, this one, that one, but it very much depends on the individual person.
Excuse me, sorry.
Yes.
Which ones in this country? I think, because my son is on medication, it would just be sertraline. Would it be the same in the States? I think they only give children sertraline. I think that's the only option here. I'm not
Really?
sure.
That's the only
Because then
option?
if that didn't work,
Oh.
or wasn't proven to work, I don't know what the option would be.
Well, doctors are allowed to prescribe off-label.
Right.
So, all these approvals for these meds for different conditions are often driven by at least in the US, by the drug companies. Now, I don't know how it works here, but the drug company is very expensive to get an indication, we call it, sort of official approval to use a medicine for a certain disorder. There are no indications for any medicines in BDD because no drug company has ever thought they'd make enough money off of it. And they don't feel it's worth their millions or billions of dollars to go to the FDA in the United States to get official approval and to fund the studies that are needed to get that official approval. It doesn't mean they don't work. It doesn't mean that they're not safe. So we're allowed, you're allowed, yes. There are no indications, official indications for medications for tons of disorders. Because again, it's a very expensive undertaking for the drug company to get that approval. It's kind of a marketing decision. They think it's worth their money, the money they have to invest to get the approval. Doesn't mean they don't work. So we really look more to the scientific literature. And the SRIs, these medicines, are often very well tolerated in kids. Now in kids, I might not use this one. Or I'm less likely to use this one in children, although I think adults, it's fine.
There was a question earlier about mixing them.
Yeah, I think I kind of like simple approaches. I don't mix them. I used to sometimes combine clomipramine with one of these other ones. You have to monitor blood levels. You've got to check an EKG with this one in particular. It's really the only one that you need to do that for, I would say. So sometimes this is different enough that sometimes I would combine with these other ones. But again, you need that monitoring of blood levels from time to time and an EKG from time to time. Make sure before you take it, you have a normal EKG. That's the cardiac monitoring. So anyone had, I'm sure many people have had an EKG. Yeah. Yeah, in our country, we wouldn't do that. But there's no downside to getting an EKG. I mean, most adults have them, every year or two anyway, it's painless, quick little thing that your GP can do. But I tend not to mix these. I tend to try and optimize the dose. I think what I definitely don't do is I don't use a suboptimal dose, especially if it's well tolerated, and then throw a second one in. Because you start running into drug interactions. It's something a little bit complicated. One can affect the metabolism of another. So I tend to keep things quite simple. If I possibly can, I'll use just one of them. And I'll try to get the dose up. If a lower dose doesn't work, sometimes people respond nicely to a low dose, and that's great. But if not, you can push it up a bit. Sometimes I'll add in another medicine, because sometimes people have co-occurring disorders that also need some treatment at the same time. Sometimes anxiety levels are so high initially. Sometimes a little bit of an anti-anxiety medicine, often just temporarily while you're giving these a chance to work, because these typically take a little bit of time to work. So, yeah?
You said that the BDD say 20% can go away with an SSRI.
Like 25, was it 25%? Completely.
To do CBT because if they stop the medication, say 2 years later, do the symptoms start to reoccur?
That's such a great question.
You said
yeah.
They feel cured. Are they cured? Has anyone ever taken an SSRI for 2-3 years, stopped, and then the BDD has not returned? Or?
It depends on the person. And we just completed a study where we asked that question exactly, except it was after 14 weeks of an SRI. We used escitalopram, and we treated 100 people, and then people were randomly assigned to continue the escitalopram or switch over to a sugar pill to see what happened. People who continued the escitalopram did better. They were less likely to have their symptoms come back. So in other words, those who discontinued the escitalopram were more likely to have a recurrence of BDD, but not everybody did. And so the question of if you learn CBT, does that protect against your BDD getting worse again when you stop the medicine is a really important question. No one has studied that. What I would say is maybe, and it kind of makes sense if you learn good CBT skills that you could practice, that if you gradually stop the medicine, that, that should help, right? But some people say, oh, we know that's true, but no, we don't know that's true. We hope that's true. So, it's interesting. So let's, if you start an SRI, one of these medicines, and you are one of those people who does really well, is there even a role for CBT? Do you need it? Because if your symptoms are that much better, there are no symptoms to treat. Now remember, about a quarter of people have complete remission within 3 months or so. Over time, people, if you stay on the medicine, you tend to do even better and better. That's the tendency. So if you get quickly better with the medication, you may still have some remaining symptoms, and CBT might be helpful for those. If your symptoms completely go away, you don't have anything to treat. So that's a difficult situation. What I might do in that situation is I might buy a self-help book that teaches CBT skills. And why not? Some of the cognitive techniques are good for everybody on the planet to learn. We all do things like we think we know what the other person's thinking. We do mind reading, but do we really? We do that all the time. Oh, she must be thinking whatever, whether you've got BDD or not. Some of us are catastrophizers. Oh, I know it's going to go really badly. It's going to be terrible. That's another thing. When you do CBT, you learn, ooh, that's something called catastrophizing. Why was that my tendency? And maybe I can think differently about how things are going to go. So I think some of the CBT skills are good for everybody. And why not? There are a number of self-help books that teach CBT skills. David VEALE has one. Sabina Wilhelm has one. I think if you're more symptomatic with BDD and you have full BDD, I think a self-help book is probably not going to be sufficient. In that case, you'd want to see a therapist.
Is there any evidence that those drugs, those pills you're talking about there, the effectiveness of them wanes with time?
No, if anything, it's possible. A small proportion of people, I think, find the effectiveness wanes. Very few. I think it's often that they're not taking it every day anymore. Or they think, oh, maybe I can get by without it. So I think often the adherence is not as good. But in most cases, if you continue the medicine, you'll continue to do well. And in fact, some people find that they just get better and better and better, even without changing the dose. And maybe that's because they engage in life more. And they have more, they add more to their life and more valued activities. And, they get their social life starts improving. That can be very reinforcing too. So it may not be totally an effect of the medicine. It might also be that they're avoiding less and enjoying their life more. So for whatever reason, though, people often continue to gradually improve on the medicine over time.
There are some potential side effects.
Yeah.
What are they?
They're very non-specific. So if you get them, it's often really hard to know if they really are a side effect. But sometimes people do get them and they really are a side effect. We just did in this study I was just describing where we were comparing the medicine to a sugar pill, which has no side effects. It's like eating a little piece of bread. So we actually found that there were more side effects in the placebo group. Now, they're not really side effects. It's just that you were going to have a bellyache anyway. Or, you were going to get a little sweaty anyway because it's a hot day out. So I would say these are among the best tolerated of all the medicines that are out on the market. Although clomipramine tends to have a bit more the risk of side effects is a little bit higher, but many people do great with it. Sometimes you can use the side effect to your advantage. So if like it makes you a little sleepy, and sometimes these meds do, take them at bedtime. Maybe your sleep will be better. So the most common side effects, I would say the most common are less sex drive, some sexual dysfunction. It's not permanent, so don't worry about it. On the other hand, what I tell my patients is maybe this will, maybe this will affect your sex drive or your sexual functioning. Hard to have an erection, for an example, for a man, but don't assume that. It's just it's maybe 25-30% of patients, something like that. But often people find that their intimate relationships go a whole lot better because if you get better on the medicine and you're not depressed anymore and you don't have, your BDD is better, maybe you'll even get into a relationship and enjoy that part of your life more. So I say it may have no effect, it may have a positive effect, it may potentially have a negative effect. I find, though, that not uncommonly it gets better over time the longer you're on the medicine. But I'd say that's probably the most common side effect. I think others are sometimes people get a little tired on it, but take it at night. That can time of the day can matter. Sometimes people get a little like they've had an extra cup of coffee. That's not always a bad thing, right? So, but a little bit energized, a little bit wired, sometimes a little nausea, but if you take it with food, that can help. There's a small proportion of people who get a number of these side effects in the first week. Not most people. But if they wait another week, they often go away. Or you temporarily lower the dose, let your body ride it out, gradually raise the dose again, maybe raise it by less the next time, make the increase more gradual. You can, often overcome the side effects if you get them. Yeah?
Do you think with a CBT therapist, if they've not had experience with BDD, but
Yeah.
they've got good experience with anorexia and
Yeah.
other, do you think it can still work?
Yes, I think they've got to learn a little bit about BDD, but there are lots of great books out there that they could read. And if they have general training in cognitive behavioral therapy, it's a general treatment approach that's used for many, many disorders, then they can just buy the treatment manual. I showed a slide of it this morning, the Cognitive Behavioral Therapy for Body Dysmorphic Disorder, which I and my colleagues developed, or David VEALE's book for therapists, and they read through it. And it's session by session, ours is anyway, session by session instructions, basically, for how to treat BDD.
It's hard to tell the therapist what to use, sort of thing.
I'll tell you, I think BDD is hard to treat without a manual. I think it's easy to go wrong. It's easy to think, oh, this is OCD. And they don't take a few sessions to set the stage and find out what your goals are and explain it and help you get on board and answer all your questions, and then they just say, go to the mall tonight. Well, that's a lot of patients too hard. So sometimes I think the exposures are pushed too hard, or sometimes they have you start staring in the mirror thinking somehow that's going to make your anxiety go down, where actually it's reinforcing a ritual. So I think, and I don't blame the therapist actually, it took us 10 years to develop and test our treatment. It took David probably the same, David VEALE probably the same. So it's very hard work. And they've only been published for a couple of years. So I don't think the therapists are to blame, but I would say a good therapist would say, excellent, there are these manuals here that, and especially if you give it to them, and they still need to use their judgment. They still get to enjoy being, therapists like to use their own, but every patient's different enough so that you still get to be a real therapist. It's not a cookbook that you have to follow exactly. But I think a good therapist should welcome this, and anyway, I think hopefully they'll see it as something helpful. So, oh sure. What did I do? Okay, so one is cognitive behavioral therapy for BDD. And the authors are Wilhelm, my colleague at Mass General in the US, myself, and Gail Steckety. You can buy these online at Amazon or wherever you buy books. And then another, I think it's Overcoming BDD. I think that's the name. And this is by David VEALE and Fukin Nezaroglu. So they're both cognitive behaviorally based. There are some differences. I don't know which is better, but we've both done studies showing that our approach works. And I think if you try one, your therapist tries one, and it's not adequately helpful, you could try the other one. There are also a few self-help books, that are based on cognitive behavioral principles. Again, I think, though, if you have more symptomatic BDD, that's not going to be sufficient. But Sabina Wilhelm wrote a self-help book that's very similar to the therapist guide. And it's just intended for you to try some techniques for yourself. And whereas this is a detailed guide for the therapist to follow. And then I think David also has a self-help CBT-based book for people with BDD. So.
Sorry, can you remember? The Overcoming One self-help book.
Yes.
It's a treatment manual by David called Body Dysmorphic Disorder.
Is this a self-help one?
That's kind of a self-help.
This
Therapists can use it, but it's a self-help.
And what is the name of the other one?
I can't remember absolutely. Body Dysmorphic Disorder, a treatment manual. Or
Something like that. Okay. I think if you just look under his name online, and you all know his name, if you just look on Amazon, you'll find one for the therapist and one for sufferers.
You mentioned the books on the BDD Foundation website. They're all on there.
Okay.
You mentioned anti-anxiety medicine that you'd sometimes use if somebody was very distressed. Which ones?
So if someone's really severely anxious, these medicines definitely can help anxiety. They're good anti-anxiety medicines, but they don't kick in right away.
And often they make people more anxious, don't they?
It's a little bit unusual, possible.
What if somebody's had a bad reaction with citalopram?
Yeah.
Where they have, the sort of pumping down their arms and palpitations and severe anxiety, would they react in the same way to the others?
That's a very unusual reaction. I would wonder if they had undiagnosed panic disorder. I wonder if they had panic disorder. If you also have panic disorder, where panic attacks come out of the blue and not triggered by BDD or anything else, and there's a lot of physical symptoms, racing heart and sweating, and those, it's a real attack of anxiety, very severe. You often need to start these medicines at a lower dose. So start maybe at half the usual dose. Because if you start at too high a dose, if you also have panic disorder, paradoxically, it can potentially bring on a panic attack. But if you don't have panic disorder, you can just start. If you're anxious about medication for any reason, you can always just start at half the usual starting dose and see how you do. And, it just might take you a little bit longer to get to an effective dose. I'll tell you, though, anxiety is really complicated. And so I always try to understand what seems to be triggering the anxiety for the patient. And, I think my approach depends on that. I mean, one thing I do ask about is how much caffeine are you drinking? Because sometimes I'll find people are drinking gallons a day. I just go to Starbucks once, a couple times a day, and I'll ask how much, how big is the cup? And it'll turn out it'll be one of those. And how many of those are you drinking? And only 5 or 6, and then, you add in the Coke and all the. So I find a lot of people are overusing caffeine. I'll tell you, if you're anxious, that's the last thing you want to do. So I'll just ask, are there other sources of anxiety? Is someone abusing stimulants? That's not so common, but it's a possibility. Diet pills, those kinds of things. But I think for someone who does not, if you really need some anti-anxiety medicine, and some people really do, and often it's just temporary while you're waiting for one of these to work, I might use Clonazepam. I have to remember you have a different names here. Clonazepam.
Obviously, this is your expertise, but
or lorazepam.
Do you think that some psychiatrists, when people are having, you said you can be delusional, you can look in the mirror and absolutely think that you see this monster. That some people think, particularly if you're depressed, because obviously you are depressed because you can see this monster, that you are having psychotic thoughts. And where would you draw that line?
It's a wonderful question, and I think You could say that delusional BDD is a psychotic symptom in the sense that you're really not in touch with reality, but it's really just limited to how you see yourself in the mirror, and also, you know, those delusions of reference when someone's convinced that someone else is laughing at them or talking about them when it's not really happening. So the psychotic symptoms are limited to those two things. It doesn't mean you have schizophrenia. You're otherwise entirely rational. So I always hesitate a little bit with the term psychotic because I think sometimes it's misinterpreted to mean, oh, you know, I'm hopeless, or, you know, I'm crazy. You can start labeling yourself with all these really unhelpful terms. So, you know, I think increasingly we tend to use words like absent insight, for example, to refer to just the conviction that you look abnormal when no one else sees you that way.
So would you ever treat somebody initially if they were that bad, or say they'd had BDD and been able to control it for a long time, nobody knew, they had it mildly, they had their sort of rituals and they controlled it, and then they had maybe a very bad depressive episode or something like that, and it absolutely blew, and they were suddenly seeing, you know, really, really bad things in the mirror, and it was terrifying them, but in every other way they were totally logical. Would you ever, starting on something like that, use a bit of antipsychotic or not?
You could. Now, the antipsychotics are also a bit of a misnomer because they're very broad in terms of what they treat. They're used for depression, they're used for Tourette's disorder, they're used for lots of disorders. So you don't want to get too disturbed about the label. But yes, I think I wouldn't use them alone to treat BDD, but something like aripiprazole. Maybe they're not well studied in BDD is the problem. So this is really kind of based more on my clinical experience. Or ziprasidone. There's a whole host of them that I think, you know, you could add in. We don't have good studies showing that they work, but just clinically, I think, you know, I wouldn't use them alone. I think that I wouldn't do. I would use one of these. But I think these can potentially be added in and be helpful. I'm increasingly seeing people who come to see me for a consultation and they're already on this and they found it to be helpful, you know, in combination with an SRI. But one thing I should mention too is, and this is one of the more important things I'll mention today, is that any medication treatment has to be individualized to you or to your loved one. So I'm giving kind of general recommendations, guidelines, but it has to be tailored to you because you've got to figure out, do you have other disorders going on that might affect what you do with these meds? Are there other disorders that need attention as well that you may need medication or therapy for? So for example, these are really very good anti-anxiety meds, but you've got to be really careful with them in a person with a history of a drug or alcohol problem. Especially if they've missed you, these are potentially abusable, not by most people. But if you have a history of abusing these kinds of drugs or Valium-like drugs, you have to be careful with these. If you have coexisting bipolar disorder, manic depressive disorder, you don't want to just take one of these without also first being on a medicine that we call a mood stabilizer. Because these medicines are good antidepressants, but if you have manic depressive illness, also called bipolar disorder, about 1% of the population, these can potentially not only alleviate your depression, but make you manic or hypomanic. So, you know, getting an agitated state, too happy, euphoric, talking really fast, not needing to sleep, and that can be a problem. So you've got to first be on a mood stabilizer before adding one of these in. So that's just a couple little examples of how you need to have a good diagnostic evaluation, know what disorders you have, if you have others, and many people with BDD do, and then the treatment really has to be individualized for each person. So these are kind of just general suggestions.
Can you write down the upper limits? Can you remember that?
The upper limits?
For those medications?
Yeah, so that I use. And these are also the upper limits for OCD. It's interesting that we've kind of there's been not much more treatment research on OCD than BDD, but they're the same as many experts would recommend for OCD. Now, these upper limits, not every doctor is going to be comfortable going to these upper limits, but at least, hopefully, they'll be comfortable in taking it a little bit higher than they might otherwise. And also, as you start going up higher and higher on the dose, if you're uncomfortable or the doctor's uncomfortable, because they don't do it a whole lot, you can raise in smaller increments. Instead of going up 10 milligrams at a time, you could try 5 every couple weeks and see how you do. So the upper limits I use are 60, and these are in my book as well, my 2009 book. I sometimes go up to 120, 400, maybe 90 or 100, 450. I do not exceed 250 for this medicine. And I do not. That's the max. That's the typical max. And I would tend to check an EKG, painless, quick test of your heart rhythm and blood levels, especially if you're combining it with something else. Sorry, this is all getting to be a mess.
Do you do the blood levels to make sure it's not too high?
Yeah, I do. I do an EKG first before I even start this medicine. Just make sure you don't have a pre-existing abnormality on your EKG. And then citalopram, unfortunately, in the US, we are now limited to 40 milligrams a day. I'm not sure what the limits are here. Whereas in BDD, I would use 60 to 70. I'd go up to 90. So,
Why would that be?
because in a small proportion of people, it can lengthen a little interval on the EKG, which in theory can cause cardiac problems, but I don't know that there's ever been a documented case ever. And so the thinking of the regulatory bodies is, let's just be safe and put this limit on the dose. Unfortunately, though, it's a problem for people with BDD and OCD who might need a higher dose. But we've got all these other ones too. So,
For children, would they roughly be halved? And at what point would a child's age go from a child dose to an adult dose? Would it depend on their body weight? Because it's more complex.
yeah, I think when
It
they're
goes by their body weight.
when they're younger. Yeah, I think once you're an adolescent,
Yes.
these doses are fine. As we were talking, you know, I've talked to quite a few specialists in pediatric psychopharmacology, and they say the adolescents actually can probably get away with more than the adults because they have such good livers. Young, healthy, not diseased. You know, they metabolize the meds pretty well and fast, so that the blood levels then tend to be a little bit lower. It's only when you get to be older, like in your 60s, 70s, 80s, that you might need lower doses, right?
So 150 milligrams of sertraline for my 12, nearly 13-year-old actually isn't really significantly high.
You know, I mean, I think, you know, the typical max, I can put the typical maximums here. The typical max for sertraline is 200. That's typical.
Okay.
Typical here is 80. Typical here is like 30. Typical here is like 60.
Okay.
So, but these medicines, except for this one, clomipramine, these medicines it's called a high therapeutic index, where you can exceed the maximum dose, because the maximum dose is kind of arbitrary. You can exceed the maximum, most people do fine. It's just you may be more likely to get side effects. You may want to raise the dose more slowly.
Is there anything about my main worry, I think things I've read with my son being on them, is just that I've read some articles about not really knowing the long-term effects of a developing brain being on this sort of medication, and that is a real concern of mine. I suppose we don't know. We don't have that.
Don't really know. I don't know. I mean, as far as we know, these meds are safe and effective, including for adolescents. And we do know that stress and anxiety and depression are not so good for your brain or your body, right? So, and also with the adolescents and the kids, you know, if you have bad BDD, especially if it's more severe, your whole developmental trajectory gets off. A lot of kids drop out of school, you know, and then they're sitting in their bedroom for their teenage years. And so I would err on the side of the meds, but also the cognitive behavioral therapy.
Yes.
I think, you know, I think for an adolescent, you definitely want to try CBT.
Do you adapt it? If that, you know, with the book, would you adapt to children?
We haven't.
I suppose you haven't, no. Because I've noticed with Luca, the CBT we've been having, it's different. The therapist's saying it's different. She can't go in quite in the same way.
Yeah.
He's very resistant. He's more frightened because he's younger.
Yeah.
So I don't know the approach.
Probably the best you can do at this point, I don't know of any manualized treatment for CBT that's specific for adolescents or children with BDD. I think what I try and do is find a therapist who has a good amount of experience doing CBT for other disorders in kids. like anxiety disorders, like OCD, social anxiety disorder, and have them, a good therapist should be able to sort of combine these, approaches with approaches for OCD and anxiety disorders. And it's a bit of a creative process. We don't have a page-by-page instruction book. But at this point, I think I would recommend that.
Katharine, I've got a question. We have a support group in London that we go to, and we've asked the question several times because you're the world's leading expert. I want to ask you. I had a clinical psychologist do CBT 5 years ago with me. She said that body dysmorphic disorder is like diabetes. It dies on the day you die. You can minimise it from preoccupation and stress and say 90 to 10%. But then we've heard other stories that people have been cured.
Yeah.
In your professional opinion, is it the limiting to say 10-5%? Or have you had examples of patients that are cured, like BDD is just gone?
Yeah, I mean, we don't have lifelong studies, that would really give us that answer. But I've had plenty of patients who just get better and stay better. Some of them elect to stay on medicine. Some come off medicine and do well. Some have, I think learning the CBT skills can help. But I wouldn't make a black or white statement like, once you have this, you always have it for the rest of your life. How does anyone know? I would say we've got some good treatments. Let's give them a try. And over time, you can figure out, do you want to be on medicine? If you stop it, do you want to go back on it? Learning the CBT skills, maybe they keep your symptoms enough at bay. And I don't know also, now that we're talking about black or white thinking, of course it would be ideal if everyone were completely free. But most of my patients find being mostly free, or even partially free of BDD, is really great. And then try and put good things in your life, meaningful things in your life, things that you enjoy. And I think if you can do that, stay busy and find purpose in life. And just, I think it can just keep getting better and better. Now some people, it's not uncommon to find your BDD gets a little worse when you're stressed, but then you can find some ways to manage your stress, self-help books or a therapist who can help with that. So I tend to think more in terms of you can greatly improve, and some people will be disorder-free. But I guess I would get less black and white about you'll never get over it, or, I think most people can do really well.
Just to make sure I heard right, you said the clomipramine is the max dose is 250 you can go to?
Yes.
Okay. And I was going to ask one more question. Isn't there also antiepileptics that you can use?
Antiepileptics, yes. Not well studied in BDD, but we did a small study with levetiracetam. Small study, good anti-epileptic. Anti-epileptics are anti-seizure meds. They're used for lots of things, lots of psychiatric conditions. They're used for bipolar disorder. Some have good antidepressant properties. They're used for a variety of disorders. So we had to do a small pilot study with that. And it's not a big, definitive kind of trial, but people did well. Many did, about half people. We see higher response rates with the SRIs, actually, but some people did quite well with that. And then, I think especially if you also have a lot of mood instability, a lot of ups and downs, and maybe a little bit of a hint of bipolar disorder, something like that, the anti-epileptics can be really helpful. So I wouldn't rely just on them to treat BDD, but I think depending on the specifics of your symptoms and any, anything else that may be going on, they could be used as an add-on medicine. Yeah?
So if you have bipolar as well, then anti-epileptic would be better?
Well, I think if you have bipolar, first you want to make sure it really is bipolar. I think it's sometimes hard to diagnose retrospectively if the therapist or the doctor can't see you in person in the midst of an episode. But if you do have bipolar disorder, you would not want to take one of the SRIs by themselves. So these are the SRIs, right? You'd want to first have a mood stabilizer, which can be one of the anti-epileptics, can be lithium, lamotrigine, or one of these. Then there's a whole class of these. So there are many medicines from different classes so the antipsychotics, these kinds of meds, the mood stabilizers like lithium or the antiepileptics. You want to make sure you're first on a good dose of that and get some good stabilization of your mood. And with lithium, you check a blood level, and you can with a few of the others as well. And then, only then, would I add one of these. And in most cases, the mood stabilizer will protect against the risk that, these will make you too high. Yes?
Do you have any tips on how to get somebody to understand that they've got BDD?
Oh, it's so challenging. I would love to hear from some of you what has worked with you, what has worked with family members. If you're a therapist, what has worked with your patients? I mean, it's hard. I think you say, I think you've got this disorder called BDD, and it's common and it's treatable, and see if they'll read something about it, find a good website, the BDD Foundation website, come to my website, book. Yeah, I think, one approach that David VEALE uses, which I like a lot, is theory A and theory B. Some of you familiar with that? Or you want to comment?
Yes, maybe if someone doesn't want to admit that it's imagined, then it's maybe that person can admit it's an obsession.
Yes, exactly. So wonderful advice.
Even,
Yeah.
When he or she thinks I'm ugly, but it's an obsession that I'm so preoccupied with.
Yes, absolutely.
Then there's
They might agree.
that start.
Yeah. As I mentioned earlier, I would not get caught up in what they look like, because there's probably going to be no agreement about that, right? Because I think they do see something differently than others see. You're not lying, but they're seeing what they see, probably because they're focusing on the detail, as I discussed this morning. And so I think exactly that. Maybe focus on the things you can agree on, that you're obsessing a lot, and it's making you depressed often, and causing anxiety and interfering with your life. And are you just willing to give the treatment a try? And you be the judge. If you're willing to just try, what do you have to lose to try it?
Once she will understand she's got BDD, it's a big step, and you can move forward then.
Yes. But, I think one thing David VEALE does that I like very much is, theory A is that you don't have this disorder, and, your view is correct. And theory B is maybe you have BDD, and maybe it's worth trying something that has been so helpful for many other people. Why not give theory B a try? You may not believe it, but maybe just give it a try. Maybe you don't even have to believe you have BDD, but are you willing to just try the treatment? You can always go back to theory A, but it's making you kind of miserable.
Do you think the addiction to the mirror is a telltale sign? Because someone who's not happy with the way they look, even someone who, say, has acid thrown in their face, so Katie Piper, I don't think she would do the same thing. For BDD, like a heroin addict with heroin, or an alcoholic with alcohol, we're addicted to the mirror. Do you think, it's not normal behaviour, is it, for someone without BDD? Because her daughter is hours in the mirror, and she doesn't think she's got BDD.
Yeah, that's a very good clue.
Even if you don't know the way you look, someone without BDD doesn't stare in the mirror for 8 hours, do they?
Yeah.
Yeah. So that's sure.
It's a very good clue that someone has
It's a
BDD.
telltale sign in the mirror, I think.
Yeah.
Trying to tell someone that.
Is there a difference though when it's something that
Sure.
possibly by
Yeah.
someone else?
Uh-huh.
Is there?
Yeah.
I have had this since I can remember since I was 3. I've always had this. Is this inability to produce or retain serotonin, is that genetic?
It's probably genetically, there's probably a genetic component to BDD. I don't think it's the whole story. It probably arises from a combination of genetic predisposition. And we don't have a gene for BDD. We don't know what those genes are, but probably a genetic predisposition. Like it's more common in identical twins than fraternal twins. Identical twins have the same genetic makeup. And BDD is more common in people who have the same genetic makeup. So there's probably a genetic component to it. But probably in life events probably make increase your risk too. I think it's a matter of a lot of little risk factors, or maybe some bigger risk factors combining together, that create this disorder. We don't know exactly what's causing it. But yeah, we do think that there's, something, this is a brain-based disorder. And what we really need in BDD is studies of brain scans, like fMRI scans, before and after treatment to see what happens. Because those studies have been done in OCD, and what we know in OCD is these medicines in OCD make the brain normal again. And CBT as well. I showed you, I don't know if you remember a scan I showed you this morning, where that sort of obsessional loop in the brain that you can see on an fMRI scan that we see in BDD and OCD. In OCD, it all becomes normal again after you've responded to treatment, whether medication or therapy. Probably the same thing in BDD. And yes, it probably does involve some dysfunction of serotonin. Yeah. What's that? It's really complicated. It's probably under-functioning of serotonin, probably just not enough doing what it's supposed to be doing in your brain. They boost it. They boost the effects of serotonin, yeah. Yes?
My daughter has BDD, and she has taken citalopram
Yeah?
for 7 years. She used to stay in the mirror for hours, skin tightening, all this stuff. And she took 40 milligrams per day.
40?
40. When she decreased the dose, it was her choice, without telling me anything or to her psychiatrist. She decreased to 20 milligrams 2 days.
For 2 days?
For 2 days, yes.
Mm-hmm.
And she got surgery because her face was...
She thought.
Yeah, she got a surgery.
Yeah.
Of course, she was not happy.
When she cut down on the medicine.
Yeah, of course, she was not happy with the surgery,
Yes.
but in time, and it happened all of a sudden. So she passed away by a glass, by a window, not by a mirror, and it was like a panic attack.
Mm-hmm. On less medicine.
Yeah, on less medicine, and after the surgery.
Yeah,
And when she started to take the normal dose, she's very good right now, in good health. She's functioning, has a job, so everything. She has a master's degree and so on. So I'm against the medication, but I can tell, seeing my daughter, that it's a huge difference between not taking, in BDD at least, and taking. And she used to have also bulimia. She had treatment, cognitive behavior therapy for bulimia, that it's different because I come from Romania. We don't have a specialized CBT for BDD. Mm-hmm. So it helped her for bulimia, but not for BDD. And in fact, the bulimia is what you see, for instance, but inside was the BDD on the major illness was
the
BDD.
major issue, and the medicines helped her a lot.
And right
Yeah.
now she's 31, so she has taken the medication for 7 years. I don't know if it's a long time or not, because at some point her psychologist told her that you take too much medication. But her psychiatrist recommended her to take
If you're tolerating the medicine and it's given you your life back, I wouldn't say she's taking too much.
Yeah. Discovered it by a chance when she was 24
Yeah.
because of Rhode documentary, because I didn't know what happened. It's another word. It was like a shock for me because I didn't know what happened to my child.
Yeah.
My child that was very good in mathematics, physics, and all of a sudden. She wanted, she left an exam because she considered she was the ugliest and the oldest. And she left the exam and tried to hide after cars.
At least she took the medication.
Yes, she took, but even now, I told her, come with me, I bought 2 tickets. It's a chance to come here. It's the first BDD event. You should, it's your future, in fact. And she didn't want to come. She told, no, I won't come. Okay, but maybe in time she will come. She will have also the CBT. But even right now, she does not recognize that she has BDD. Maybe I don't have BDD. And I told her, okay, you are 31, And you spend a lot of money on dermatology and on your surgery.
Thank you so much.
If you compare yourself to the young people your age, so they have other hopes from the life. And the life, they have other, I don't know, how the purposes in their life. Not just surgery and dermatology.
So thank you very much for sharing that. Appreciate, and we're going to let someone, thank you, we'll just let someone else. SNRIs, not as well studied. I would consider them a second line treatment, like venlafaxine. I'll go as high as 450, but I'd go with one of these instead. Every once in a while, I'll combine one of these, although not clomipramine, but I'll combine one of these with venlafaxine, but only if I've optimized the dose of one and it's not working well enough, but partially, then I might add the other in. But I think some people do well with it. It's just not as well studied as these. And interestingly, the jury's still out for OCD as to how good these SNRIs are, the venlafaxine-like medicines, whereas the SRIs are really highly recommended. And BD, with pharmacotherapy of BDD and OCD are pretty similar. There's some differences, but really pretty similar. So, yeah, do you know someone who's done well with it?
My sister's taking 150.
150, so that's kind of a low dose. So if she's tolerating it well, that's a pretty low dose. And so sometimes a higher dose is helpful. Yeah, yes?
Moving from one antidepressant to another, would you expect these effects to kick in a bit quicker? Would you still say you should give it that sort of 8 to 12 week period?
I'd still give it that amount of time, because you're probably switching from one to another only if the one they're on is not working that well, or maybe it's not that well tolerated. Is that what that was? It's better. Yeah, no, you probably still need the full 12 to 16, 14, 16 weeks of the newer one. You don't have to be on the high dose for that long. I'd be on the highest dose you can get to for at least 3 weeks or so. 2 to 4 weeks, perhaps. So, in a total trial, if your doctor feels comfortable with it, I'd at least get up, if a lower dose doesn't work and the person's doing well. I mean, one thing you can do is you don't have to go quite that fast. If you want to, you could sertraline, you could start at 50 for 2-3 weeks. And of course, it all depends on how the person's tolerating it, how quickly you go up, and what they would like to do. Here, yes, I'd like to try and go faster because I'm suffering. And others are a little bit more cautious. So it's a dialogue between the person, the sufferer, and the doctor. We could go up, 50 for 2-3 weeks, and then go up to 100 for a few weeks, and gradually get it up. I'd at least get it up to 200 to 300, at least. And I'd at least get up to these doses for all these meds, if at all possible. So the 30, 80, 260, 300, and this is all in my book, 250, and with this we're limited to 40, so I don't use it so much. I'd at least get up to these. And then, if you and your doctor feel comfortable gradually going up to these kinds of doses, if they're tolerating it, what's that?
It can be fairly long term.
Yeah, as far as we know, they're really quite safe over the longer term. And I mentioned that this morning, that big study that just came out, showing that these medicines cut the risk of death and heart attack and stroke by 50%. And many of you are probably taking statins, the older people in the group. They didn't have that effect at all. These were the fascinating, huh? So, I mean, we need more of those studies. But
Is that not connected?
this one, potentially, that's why I get an EKG.
What about with pregnancy? What would people do?
That is a really complex issue. And what I do, I don't know what kind of access you have to pregnancy specialists in the US who specialize in these medicines. I always first I say to my patients, please plan your pregnancy ahead of time if at all possible. I do advise good contraceptive use on these meds, really while taking any medication at all. And then if you think you want to get pregnant, talk with your doctor ahead of time and plan it. And it's a very individualized decision. I have my patients get a consultation from a doctor who specializes in use of these meds during pregnancy. And because they know the latest, most cutting edge research findings. They may be doing the studies themselves. It's very individualized. On balance, as best we know, these medicines are really okay during pregnancy. And it's probably better for the developing fetus, for the woman, to be on one of these and not be totally stressed out and depressed and anxious, than to have a full relapse of BDD or depression or whatever else and be totally stressed out. That's not good for the developing fetus. Now that's, though, an advantage of CBT, is if you really learn some good CBT skills, then of course that's perfectly compatible with being pregnant, and it's not going to be harmful to the fetus. But I think it's a very individualized decision, and it really depends on how severe your symptoms are without the meds, possible risk of relapse.
So there is a risk then, basically.
The general, this has been studied and studied and studied. You know, the problem is it's impossible to do the perfect study. It's impossible to do the gold standard study, which would be you take pregnant women and you assign half of them to take a sugar pill and half to be on the drug. No one will ever, during pregnancy, no one will ever do that kind of study, right? So you always have this kind of imperfect data and you're trying to figure it out. I would say the bottom line, though, is, of course, if you can be med-free during pregnancy, that's probably better. But you don't want to, you know, you want to be symptom-free as well or have your symptoms improve. So on balance, I think these meds are thought to be okay during pregnancy and better than being severely ill. On the other hand, that's an advantage of the CBT, is if you can get your BDD under control with that, then you don't have to have concerns about taking meds during pregnancy.
What percentage likelihood, leading on from that question, of BDD sufferer passing BDD onto their child? Do you know that?
The risk is low.
Low?
Yes. So, you know, we found that, like, you know, maybe 6% of people, something like that, of people with BDD have a first-degree relative with BDD. So the risk, maybe 6%. So the risk that your child will have it is low. Yeah, it can run in families, though. But yes.
You know, I'm not sure how. You know, one man's obsessive scientist, who's the most brilliant scientist in his field. You know, it could be, circumstances change, he could have full-blown BDD and spend his life in front of the mirror.
Absolutely.
So I think it's very difficult to be objective about this, and everyone's probably got a bit of it in us somewhere. We've all, you know, I've grown up and I've wondered about my nose, etc., and I've never developed into that sort of, it's never got obsessive, but there, for the grace of God, I could have gone that way.
Absolutely.
So I'm not sure that we haven't all of us got a bit of it in us. And at different areas, it gets sparks, and unfortunately it happens. I don't know.
Well, appearance dissatisfaction, appearance concerns are really common in the general population. It's very hard to find even one person who's perfectly happy with everything about how they look, right? So it's really common to have some dissatisfaction. What's different about BDD is, you know, it becomes this obsession, and it starts taking up a lot of your time, and then it starts affecting your life and causing a lot of emotional distress. But it does kind of echo these kind of normal concerns, but it's at a different level. And it can happen to anybody. Absolutely anyone can get this disorder.